My name is Lien. I'm an optometrist based on Larrakia country in the Northern Territory of Australia. You're listening to Talking Eyes. This episode, we're diving into something lots of people are curious about, interested in being a candidate for, but scared to take the next step. And that's right, I'm talking about laser vision correction. It's a big deal. It's a huge decision to make this permanent change to your eyeballs. So this episode is all about giving our listeners clear, simple answers on whether they should take that leap to lose their spectacles and contact lenses. And I'm joined by Dr. Ben LaHood, a specialist refractive surgeon and a global education leader in this field. Let's dive straight into where laser eye surgery fits in. What does laser eye surgery mean?
Yeah, I think that's the most important point, because no matter what surgery I'm talking to a patient about, they'll say, can I do it with a laser? And, there are different lasers for different parts of the eye. So, there's laser of the retina to try and weld holes, and there are different lasers for different parts of the eye, but the laser we're talking about are lasers to reshape the cornea, so reshape the front window of the eye. And I basically would say to them, think of your eye like a camera, and what we're doing is we're making it in focus. So when we reshape the cornea, we're really stamping either their glasses or their contact lens prescription onto the cornea, changing its shape to make it a shape that will focus light on the back of the eye on the retina. So this kind of laser, and there are different types, but we're reshaping the cornea.
The sort of procedures we use today are very, very different from procedures that have been used throughout history. I mean, there's a little bit of a backstory in terms of centuries of people attempting to reshape the lens or stamp a prescription on the lens of the eye. My favourite story is the kid who was wearing some spectacles that were made out of glass lenses. One of the reasons that optometrists don't use glass lenses in practice anymore is because these glass lenses broke and penetrated the front surface of the eye, the cornea. And these shards of glass were removed by a Russian ophthalmologist, Dr. Fyodorov.
So the idea with that was, if you slice a certain thickness into the cornea, you're able to change its shape. And basically, when you make cuts in a cornea, you will weaken the structure and it can flatten. And so people realized that if they made a lot of radial incisions around the circumference of the cornea, they could flatten the central portion and cure short-sightedness. And it was a really successful procedure, but like any early procedure, we've found that there were repercussions of that and negatives, people gradually becoming more and more long-sighted over time, fluctuations in vision through the day. And so now we are still seeing people that had this surgery done, in the 80s and 90s, that are now, we're dealing with them in terms of cataract surgery, and they're difficult to deal with. So that's sort of a remnant of the past, but the idea remains that can you flatten the cornea and cure short-sightedness? And you can, but we now have more elegant and controlled methods rather than incisions into the cornea.
There's a few different types of procedures that are out there, aren't there? There's LASIK, PRK, SMILE. Can you explain those procedures in really plain language for our listeners?
Yeah, absolutely. This is what I do, 20 times a day. So they are the modern procedures of choice. There are other variants of them, but these are the procedures that any modern laser surgeon should be talking about. So with PRK, or photorefractive keratectomy, this is a surface laser. So imagine your cornea as a curved window, and the very most simple procedure is to use a laser to vaporize tissue in a controlled manner and take some tissue away from the top surface of the cornea to make it flatter. So taking more away from the center than the peripheries and basically flattening the cornea, making it less curved. Nothing touches the eye, so good for squeamish people, but a longer recovery because it has to heal like an abrasion on the cornea. So that's the most simple form of laser surgery. LASIK, so that is where we're basically doing the same reshaping, but doing it under the surface. So these days we'd use a femtosecond laser to create a flap, so a very thin flap on the cornea. We open that up, and I know this will sound terrible to listeners, but none of it's painful. Open that flap up, do that same reshaping that we did with PRK, the same laser, but then put the flap back down. And the benefit of that is a very rapid recovery. The downside of that is we are using a bit more structural stability of the cornea. And then we've got SMILE, which is a more modern technique. And when we say modern, it's been around for over 10 years. So, none of these are absolute fresh out of the blocks, but SMILE is where we use a laser to outline the shape within the cornea. So within the sort of middle of the cornea, we'd use a femtosecond laser, the same one that creates the flap for LASIK, and that would outline a shape like a lenticule. So a lens-shaped area of corneal tissue would then be physically removed through a keyhole. So it's a little bit more surgical, but a little bit more gentle on the cornea in terms of structural stability and dryness. So they all have their pros and cons, but all of them can treat short-sightedness. And then in terms of treating long-sightedness, LASIK has been the one technique that's able to do that. But in more recent years, in the past 2 years, SMILE has been able to. And then I think we know, but I think it's not widely known, that astigmatism can also be treated by all three techniques as well.
Yeah, I was going to ask about astigmatism because patients are always worried that they have a stigmata in their eye.
Yes, it's a very common term. And, I feel like I've really made my career on treating astigmatism. And I'm still finding that my patients ask me the same thing. They'll say, I didn't realize you could treat astigmatism. And for anyone listening that's not sure what astigmatism is, as a Kiwi, I would say astigmatism is when the front of your eye is shaped more like a rugby ball than a soccer ball. Not a footy. Never say a footy. And then, with treating astigmatism, we're really trying to make that rugby ball a more regular spherical shape in most instances.
These procedures have been around for a little while now. Is one approach better than the other, or does it depend on the person's eye? How are you sort of making a judgment?
Yeah, it really is, and it should be on an individual basis. I think a patient can come in with a preference, and that's absolutely fine. But then I think the surgeon should guide them as to what's most appropriate for their eyes. And what I usually talk to patients about is, let's imagine we have a completely normal, healthy cornea, healthy patient, your standard patient that just wants to get rid of their contacts or glasses. I'll usually have a discussion where I'll say, well, PRK is extremely simple, but it does have a long recovery. When I do an audit at 1 month after PRK, 50% of my patients are perfectly happy and discharged. 50% are still recovering. And when I say recovering, they're seeing well, but their cornea is still remodeling and they're still about to reach their peak vision. So it is quite a long recovery, and there are moments where it's not as comfortable. So if I had someone that wanted the very most conservative option, which removes the least amount of tissue and leaves the cornea at its most robust, PRK is a very good option. Also, in terms of dryness, for PRK, we're not really disturbing the deeper nerve complexes, and so not quite as much impact on dryness long term as the other techniques. And then between the other two techniques, which have a relatively rapid recovery, I love LASIK. I think it's a great technique, and I think if it had come after SMILE, we'd all be saying how great LASIK is. LASIK's had some bad publicity in terms of causing dryness, but if someone has a nice healthy eye, I think that's extremely rare to be a problem. So I would usually say to a patient, if you want an extremely rapid recovery where the next day you're seeing very well and could do everything, LASIK is unbeatable. And then if you had any kind of dry eye concerns, SMILE would certainly be a good option because it's a little more gentle in terms of dryness. Perhaps your nighttime vision may be a little bit superior with SMILE over LASIK, just in terms of it tapering off to the edges as opposed to having a very definite flap edge. So maybe a little bit less halo or better quality of vision at night. SMILE is generally a little more expensive than LASIK, just a few more moving parts. But as a surgeon, SMILE is wonderful to perform because it's extremely quick. It's very satisfying. You're only using one laser, so you can get through maybe a bigger workload more easily. So for most patients, they'll say to me, well, I don't want to have PRK because I don't want to have the long recovery. Can you tell me which one out of LASIK or SMILE would be better? And I'll usually say, well, with LASIK, you can expect a 1-day recovery and then very good vision, but maybe a little bit more dry. With SMILE, probably the recovery we're talking over 2 to 3 days. If you do any kind of martial arts, any kind of risk of trauma around your eyes, the LASIK flap potentially could be dislodged. But I've got to say, in the last 10 years, I've had 2 patients where their flap was dislodged, and we could put it back immediately and they were fine. So it doesn't really come into it. But SMILE might be a good preference for someone that is a little bit more concerned about that kind of trauma.
So what makes somebody suitable for laser vision correction? Because I know that some procedures aren't actually suitable for certain patients.
So I like to think of it as, if you've got a normal, healthy cornea, then you're really limited by the thickness of your cornea. So because we're vaporizing away tissue, and you don't want to leave someone with a cornea that's too thin, or it could warp or buckle in shape, we're usually limited by how deep we can go in terms of leaving them with enough tissue remaining. So there is a limit on the upper limit of how short-sighted you could be, and for most people it's probably around -10 to -12. So it's quite high. Different procedures have different limits, but that's probably about right. For astigmatism, it's probably around 4 to 5 diopters of astigmatism, and for long-sightedness, we're not limited in terms of how much tissue we take away, but by the quality of vision that we would create. So usually you wouldn't want someone over about +5 in terms of long-sightedness. So one determinant is your prescription fitting into what's possible with your amount of corneal tissue. And then I think we're guided by other factors to do with their eyes. So if someone had an irregular cornea, even a small degree of irregularity, so if we looked at the map of their cornea, and let's say the inferior part was steeper than the superior part, it was thinner than you'd expect, then I'd be very wary of doing laser surgery because we're removing further tissue. And so if we have already a weak cornea and then we take tissue away, could we further weaken it and cause them problems long term with warpage of the cornea? So probably the two things, the information we get from our optometrist would be what's their prescription and are they stable? You don't want to shoot at a moving target. And then information we get in the clinic would be looking at how dry their cornea is, whether there are any other pathologies in their eye, and of course, whether that corneal shape is regular and would respond well and appropriately to laser.
So have there been patients who've seen you and you've steered them away from laser vision correction?
Many times. I mean, I think I portray an image of lasering anything that moves. I think that, I'll often say during teaching, I'm yet to find a problem that a laser can't solve. The reality of it is that I'm a conservative laser surgeon, and I think as you get older and more experienced, you become even more conservative because you see the problems that you might have created. And every day, I would say somewhere around 10% of my inquiries, I would say, no, you should not have laser surgery. You may find someone that would do it, especially overseas, but I would not recommend it, and I won't be doing it personally.
Okay, so these are irregularity, potential prescription that is not appropriate for the amount of corneal tissue they have, and dryness. How do you assess dryness, and is there a way for people with dry eyes to access laser vision correction?
Yeah, so in the clinic, I would assess it looking at the microscope, actually looking at the eye, asking about symptoms of dryness. We all know the symptoms of someone going for a walk in a cool breeze and their eyes tear, and that's usually from evaporation of their tear film. And so we know that laser will make things worse, at least temporarily. And so if I did have a dry eye patient and they really definitely wanted to have laser, because you've got to remember, we do have alternatives to laser. We have implantable contact lenses, glasses and contact lenses, of course, but we also have refractive lens exchange. We have other options that we can do to eyes. So if someone is really set, they definitely want laser, they have mild dry eyes, I would probably guide them away from LASIK because we know that's relatively higher risk for making things worse. SMILE would be possible if they have enough corneal tissue and suitable prescription for that, or PRK would be an option, but a longer recovery. And if they do have dry eyes, just knowing that that's probably going to be an even longer recovery because we want to get their corneal surface healed, remodeled, and then really rejuvenated and healthy again. And I think this is where you're really guided by the experience of a laser surgeon. You want someone that's seen eyes that have been okay to laser and seen eyes that shouldn't have laser. Because I'll also see patients where they'll say, look, I don't mind if I have to put a drop in twice a day of lubrication, but it means I'm not wearing my contact lenses. I'm actually a lot more comfortable out of my contacts. And so even though I get dry eye symptoms, I think I'd be okay. And so it's those sort of chats that are important.
Let's walk through what somebody might expect when they come to see you. They'll have their initial consultation, and then on the day of surgery, they'll come in. What do they expect to see or feel?
On their original consultation day, they'll be seen by an optometrist in the clinic to recheck their prescription. They'll see me, they'll always see the surgeon, they'll have a good chat, an informed consent, all the measurements. And then on the day of surgery, I say to everyone, and I think I have a good friendly relationship with all my patients, but I'll always say to them, look, there'll be no pain. There'll be no pain whatsoever, but it's going to be a weird day at the office. This is going to be a bit weird. And I think part of that is being out of control. I'm doing something to you, but I'll be talking to you the whole time. So let's imagine they're having LASIK. They'll come into our day surgery. So where I work at Adelaide Eye and Laser Centre, we have our laser suite in an accredited day surgery. So you can be assured that everything is above board, everything's clean and sterile. And that's quite unusual because there are a lot of lasers that are just sitting in a clinic, just working. And I think you've got to think about that when you're thinking where to have laser. Not to sound like an advertisement, but it's important. And so the patient will come in, they'll see one of the nurses who will usually give them a tablet of something to just take the edge off. The most common question I get is, can you knock me out? And we can't, because we need you looking very briefly at a target. Very, very briefly, but we need you awake. So once they've had that little bit of sedation, we'll put some numbing drops in their eye. They'll come into the laser suite, they'll lie down. I'll be chatting to them. We'll clean around their eyes. I'll put a little speculum in that keeps their lashes out of the way, because that's the other question I get asked is, what if I blink? You won't be able to. The laser that creates the flap for LASIK will come down to a contact lens that touches their eye. They won't feel that because the eye is numb. What they'll experience will be no discomfort, but the laser lays down a layer of bubbles. So just bubbles, no cuts, no heat, nothing like that. And that takes about 8 seconds, so it's very fast. On the bed, we'll move them to the second laser, and I will open that flap, so they'll see some shadows moving in front of their vision, but again, no discomfort. Then the laser will track their eye, and it tracks the eye many thousands of times per second. So the other concern people have is, what if I look away? Well, if you do, the laser will stop, or if you move a little bit, the laser will move with you. So it's very safe. You're not going to be like Final Destination where your eyeballs get lasered out of your face. Not at all. Then that reshaping process usually for most laser treatments takes under 10 seconds. There's a little bit of a smell, a slight barbecue smell, I must admit. That's the vaporizing of that corneal tissue. And then a little bit of water on the eye as the flap goes back down and some medicated drops. So all in all, for both eyes, treated with LASIK, from the moment you come into the laser suite to the moment you leave, probably about 10 minutes. As soon as they sit up, they're aware that they can see better than they could before, but they're a little bit foggy because the cornea is a little bit swollen. And then the next 3 or 4 hours, the eyes might feel just a little bit irritated, just a little bit gritty, a little bit foggy. And then that fog and irritation lifts over 3 or 4 hours. And I like my patients to go home and just have a sleep. The next morning, when they wake up, I sort of expect their vision to be probably about 90% of how good it will be eventually, so very good, and most people can drive themselves to the clinic. And then have a check of their eyes, make sure the flap is nice and smooth and they're seeing well, go over their drops, and then they can go and enjoy their new eyes. They can usually, what they want to do is go and buy a pair of sunglasses off the shelf for the first time ever. And then I usually see them at about a month after surgery just to check that they've finished their drops, they're happy and comfortable.
Yeah, and that's what you've described for your LASIK patients, isn't it? The ones who really like you after the surgery is complete.
They're the ones that are happy. The PRK patients, very similar process, except that instead of creating the flap, they just lie there in the laser like a concert lights show, ablates away some tissue. After that, we put a contact lens on their eye to help with healing. And instead of seeing them the next day, we'll see them in about 4 days to take that contact lens off, and then their vision starts to recover from there. So very sort of similar follow-up process, about a month. And then with SMILE, very similar to LASIK, where we'll see them the next day, but I sort of expect their vision to be maybe about 70% of what it'll be compared to, say, 90% with LASIK.
So improved, but not perfect.
Absolutely. So the next day, I'd expect anyone with LASIK or SMILE to be able to drive, and I'd expect them to be comfortable. But just in terms of their full vision recovery, a little bit longer for SMILE than LASIK.
And is it realistic of them to expect perfect vision forever?
Yeah, this is a big one. So many people will say it only lasts 10 years, right? It only lasts
Yeah.
10 years. And I think to myself, where did that myth come from? Because we're permanently reshaping the cornea. And so the laser reshaping will last forever. Sure, some people might get a little bit of regression because, most people I'm seeing about 20 or 30. And so for the last 20 or 30 years, anytime they hurt their body, it recovers or regenerates. And then suddenly we're saying, not this time. So we do have the occasional person that heals more than expected, and so their laser may wear off a touch. But if that happens, I get them back and do a little bit of extra laser. And for me, at least, there's no cost with that. Now, the thing that can change is people can have lens changes, so cataract. And my belief is that probably between the age of 30, where a lot of people are getting laser, and the onset of presbyopia in people's early 40s, they probably feel as though, did my laser wear off? Because I'm starting to need reading glasses.
The 10-year myth.
I think that's where it comes from. And so I say to them, look, your distance vision will remain excellent, but you may start to lose your near vision. And so that's where probably in people's late 30s to early 40s, we start thinking about trialing monovision, where we might leave one eye a little bit undertreated to try and prolong their time without reading glasses. But in terms of should laser last, it certainly should. It should last lifelong.
I mean, one of the things that I always say to people who see me with regards to laser is that you guys are treating somebody that is a living, breathing human being. You're not remolding glass. You're not just lasering or etching metal. They're living cells. And so changes can happen to their bodies, and that's probably what influences future changes as well. It's just that they're dynamic human bodies.
It's so true. I wish everyone was as reasonable as you. But that is the honest truth, is that, the human body may change. If I did nothing to your eyes, they will change. So, even when we take biometry for surgery, we take biometry from 2 different machines, or 10 minutes later we get different measurements. We're measuring a liquid surface on a curved biological structure.
Yeah.
We try to be as precise as we possibly can, but gee, the odds are against us. Like, it's not easy. And some of this technology is incredibly precise and accurate. But like you say, the human body is the human body.
And there's some common side effects as well, actually, from laser that we've touched on earlier. Dry eyes is probably the big one. It probably receives the most publicity from people who have had LASIK in the past and have had dry eyes affecting them. And I've done an episode on dry eye disease. We treat a lot of dry eyes here up in the Northern Territory, and it can be debilitating.
I think being a laser surgeon in the driest city in the driest continent on Earth is a terrible thing to do. I wish I lived in Singapore, because all of my patients, when they go on holiday to Bali, they're suddenly like, oh, this is fantastic. Humidity plays a huge role. And so my feeling is, because there has been a lot of publicity about laser causing dry eyes, and specifically LASIK. And as someone that does do a fair bit of social media, I am aware that when I speak about laser surgery, there are a lot of anti-LASIK crusaders, especially from the US, who are really concerned about laser causing dry eyes and it not being well talked about. I think what they're missing is that a good clinician talks to their patient about that risk. It is truly informed consent. And like any surgery, there are risks. So I can hand on heart say, thankfully, I've never had anyone who has had a chronic disabling dry eye problem after laser, but that's probably because I will deny certain people having laser. Now, I've definitely treated people with bad dry eye after laser that I think should never have had laser treatment overseas or other centres. And I'm not saying I'm the greatest in the world. I'm not at all. And I've made mistakes too. But I think that if you are a young, healthy person appropriate for laser without dry eye problems, the risk of developing considerable dry eye that is chronic and worrying is very small. And I don't ever want to reassure people too much, that is a risk. But I think there's been too much fear-mongering about laser causing dry eye, and that's a bit of a shame. But in terms of all laser procedures, they do cause dryness temporarily, but the vast majority of people get through that.
And we're finding any sort of ocular surgery can cause dryness because a lot of it is the result of inflammation. Can we quantify that risk?
It's a little tricky to gauge, to be honest, because I think you'll get varying reports and I think you'll get a huge amount of bias in a lot of those studies. So the vast number of studies that are published are positive and show an extremely low rate of chronic dry eye after laser procedures. But I think anyone that runs a reasonable volume laser practice knows that it is an issue. And it's definitely, in terms of calculating that risk, the risk gets worse as you get older, without a doubt. I've got a lot of colleagues that won't do laser on people over 40. I personally don't do SMILE on people over 40, just because of corneal biomechanics not being quite the same. I'm definitely wary of talking about dryness when people are over 35. The older you are, the higher that risk. And if you already have pre-existing dry eye meibomian gland dysfunction, usually your risk is significantly increased. But in terms of quantifying it, I think for a healthy young person undergoing any laser procedure, I would expect the risk of a chronic dry eye problem to be less than 1 in 1,000.
Are there any other serious complications that might result from laser vision correction?
There certainly are. I think the most serious would be the risk of what they call corneal ectasia, so warpage of the cornea. So basically, as I was saying, thinning a structural part of the wall of the eye. The cornea is a structural part of the eye, and we are thinning it. And if you had a genetic predisposition to your cornea becoming less stable and the collagen fibers slipping over each other, combine that with thinning the cornea with laser and potentially someone rubbing their eyes with allergy, and you can further thin the cornea and warp its shape and make it irregular, and potentially that can mean needing to go back into wearing hard contact lenses. So that's something we talk to every single patient about, but we have some great devices now that can assess that risk in terms of the shape of the cornea and even the corneal biomechanics now to really assess an individual risk. So the average person with a nice healthy shaped cornea, we're leaving them with plenty of residual tissue. The risk of causing an ectasia or warpage is infinitely small, but it's not zero. So I think that for me, I bring every patient back at a month and they get pretty decent warnings that if they notice any changes at all to their vision after that, they come and see me straight away. There's an open door policy. But I think the risk for a young, healthy eye and not taking away too much tissue, no preoperative risk factors would be vanishingly low.
Finally, can you sort of give our listeners tips on what they should be looking out for in terms of a clinic, in terms of how trustworthy or valid a clinic might be?
It's tricky because refractive surgeons, by nature, we advertise business to consumer, whereas for a lot of other procedures, say cataract surgery, I'm fully reliant on optometrists referring patients, GPs referring patients, and so there's no particular bias or even advertising there. But with laser surgery, we have to actually tout our business. We actually have to advertise, be out there on social media, talking to groups about it. And so I think you do have to be wary that not always the loudest person is definitely the best. And just because they're old doesn't necessarily make them experienced or good. What you want to look for is, I think, a surgeon with good qualifications, so usually members of different refractive surgery organisations. For me, I think I would like to see someone that's active in the academic space as well, going and talking at meetings, sharing their knowledge, teaching, I think is nice. And I suppose just experience. You cannot beat experience with these things. So it's tricky when you start in this field, you don't have experience, and no one likes to be the first patient anyone's lasered, but someone has to. But I think someone that is working in a practice where there are experienced surgeons can have that oversight or mentorship. That's a good sign if it's a group practice. But if it was someone just by themselves, maybe didn't do a lot of laser, didn't have a lot of experience, it would be a little off-putting. It might be noticeable from a lack of Google reviews. And I suppose the other side of it is we do see a lot of people, and this isn't to put them down, but there are people that it's not their subspecialty. maybe they are a pediatric ophthalmologist, but they do a little bit of laser. And that's fine, but nothing really beats, it's your bread and butter, that's what you do, that's what you eat, sleep and breathe, because that means you've seen a lot. You've seen the good, you've seen the bad, because as people will have noticed, so much of this is actually coming, meeting, discussing, and subjectively deciding, would this be an appropriate treatment? So I think just seeing someone where they are truly a refractive surgeon is what I'd want to see.
And it's hard to make an assessment really from a position of not knowing the field altogether. I think a really good point of contact for people would be their primary eye care practitioner, their optometrist, because we do see the
you see the good and the bad. You do.
The ugly. And we do have people that we trust and we work with. So I think if you are wondering out there who you should be going to see, and just for an initial assessment as well to understand whether you are a candidate for laser vision correction.
And also just to see if you get along, come along and meet them, because it's not uncommon to be seeing someone and they've had an assessment elsewhere and they didn't feel good. And whether that's because they felt like a conveyor belt, cookie cutter approach, you'll sometimes strike someone like me that maybe talks too much. I think getting to know your patient and what they need is so important. So there's a lot of meetings these days about reducing chair time, but I think you have to optimize, make the most of that chair time and actually get to know your patients. But I totally agree. Where I work, I think people imagine that optometrists are against laser because they lose the glasses or contacts, but they're not. I think probably a huge percentage of my laser patients are actually referred from their optometrist, which is lovely. But you're totally right. They get to see the good and the bad.
We do, absolutely. Look, I hope everyone listening to this episode feels a little bit more confident and informed about laser vision correction. It's always a bit of a mystery to optometrists as to what ophthalmologists are actually getting up to. So I always like to shine a light onto this sort of stuff that you guys get up to as well, from that referral piece where I've sent somebody to see you but have no idea what they're getting up to.
For a lot of optometrists, if they ever want to come and see behind the scenes and see the magic happening, most of us that do laser would be more than happy to have someone observing, because it's not stressful. There's a chance to have a chat. You can have a look. And, it's quite a nice environment. I think for the patients, they also get surprised straight afterwards. Most of them will say, oh, that was okay. That was fine. It's more the anticipation, or like you say, not knowing what's going on.
And it's such a life-changing decision to make as well. So it's so great to be able to inform people of what to expect. Thanks so much for joining me, Ben.
Oh, thank you so much for having me. It's been a pleasure.
Thanks for joining me this season to talk cornea. There'll be a few extra resources linked in the show notes. I hope you found today's conversation valuable. If you enjoyed the episode, please like, follow and share my socials and the podcast with anyone you think might benefit. For my eye care colleagues, I've produced a special edition educational podcast for you, which will be available exclusively through the Optometry Australia and My Vision platforms. It's where you'll find a lot more technical jargon, but real clinical pearls to complement the season. Thanks for listening. This is Talking Eyes, and I'm your host, Lien.